Okay. Well, at least we know he's there now. If we can just get him on. How are you doing, Marion? You still with me?
Yeah, I don't see him now, Professor. I don't know. He's not on the backstage, so I don't know where he is. Yeah.
Okay. He's calling me back. Yeah. Yes. She says you're not backstage. I'm not sure which link you signed on to.
I got him. I put him already.
Wait, hold on.
I got him.
She's got you. She's got you. Yeah, Marion's saying she got you.
Yeah, he just needs to accept being promoted as a member.
Accept. Did you see where you can accept? Yeah. So he joined as a panelist, Marion. So now you want to bring him from the backstage?
Yeah, he's here. I think Professor Schnatz, if you can turn on your video.
Turn on your video and your audio.
Yeah.
Oh, good. Now we hear you.
All right, I'm gonna hang it up from here. Start video. All right, you can hear me at least. We're getting there. Let's see if I can get my camera working. What the heck is?
There you go.
There we go. There we go. Good morning, everybody. See there, I was watching everybody make the nice smiles and get a good picture, and that was frustrating. I guess I was on a wrong link. So,
well, we've already introduced you. So I think if you share your screen and bring up your slides, we can get started.
All right. All right. Share screen.
I'm going to turn off video until you're done, so it doesn't take up some of the screen.
Perfect. All right. All right. Is everyone seeing?
You're sharing.
Slides.
Slides are not up yet.
How about now?
No, it just says you're screen sharing, but.
Okay.
There you go. Disclosures. Yes, your slides are up. Yeah.
You got it? I think there's a delay. Hopefully the internet's going to be okay here. If there's a problem, someone just shout out and I can turn my video off because maybe that's taking some of the internet speed or power. But welcome. Great to be here. Sorry about those technical difficulties. But let's get started. We'll jump right in with genitourinary syndrome of the menopause. And I have no disclosures. And so we're going to define and discuss the signs and symptoms of GSM. We'll talk a little bit more about that terminology in a minute. We'll review the prevalence of GSM and the impact on postmenopausal sexual health. We're going to talk a little bit about the vaginal microbiome. I've been a lot these days about microbiome in general, and so it's kind of interesting aspect to this element of GSM, vaginal health, and HPV, the human papillomavirus. And then we're going to talk a little bit about non-pharmacologic and pharmacologic treatments of GSM, and then we'll briefly discuss the management of GSM in breast cancer survivors and added some additional slides just recently to kind of pull in some of the latest information, because this, I find is one of those areas that that really causes some confusion and concern both to the patient and the provider. So, so now the terminology GSM, every year we do these talks, Steve. Everyone on our panel keeps getting younger. I don't know why, but there may be some of you that are very familiar with this term because it's been around a little while now. And I think you were in the room when I was there also, Steve, when we discussed changing these terminology. And we renamed it from vaginal atrophy. Vulvovaginal atrophy is still in existence. It's not like we banished that term, but we tend to use the terminology genitourinary syndrome of the menopause a little bit more now. It's a little bit more comprehensive. VVA just talks about the vagina, where GSM is really the genital tract. And if you look at this photograph here, you're going to get a sense of the areas where there's a large abundance of estrogen receptors. We know there's estrogen receptors in many areas throughout the body, but very high intensity of estrogen receptors throughout the entire genital tract. And so this is a condition that affects all of these organs, not just the vagina, but the urethra, the base of the whole bladder, but really the base in particular. And so that's really kind of the origin of that terminology. Now, in terms of the signs that we look for and the visual aspects to it, hang on just a second while I close this door here. Sorry about that. So now, if you think about your exam, you're going to notice that there's narrowing. You see how much narrowing there is here. You can get a sense of the pallor, certainly the loss of rugation. You see what's referred to here as the telescoping of the urethra, loss of the easy elasticity, and really some friability of the tissue is what we notice on examination. So this condition of GSM affects the vast majority of menopausal women. The estimated prevalence is between 50 to 70%, but really if untreated, unless there's another source of endogenous estrogen or exogenous estrogen, it really affects every postmenopausal woman. And we'll talk a little bit more about the onset and duration and so forth in a few slides. But it's a progressive condition. It worsens with time, and the loss of estrogen leads to these changes that we talked about in really the entire, the labia, the clitoris, the vestibule, the vagina, the bladder, and the base of the uterus. So in terms of symptoms of GSM, we think of breaking it into the genital, sexual function, and then the urinary tract aspect to it. Genital, the dryness, burning, irritation, symptoms that we're very familiar with our patients describing. Sexual function, there's a lack of lubrication. There's a discomfort or pain with intercourse, leading to what we refer to as dyspareunia, impaired sexual function overall. And then from the urinary tract standpoint, urgency, dysuria, and recurrent UTIs can also be a part of the spectrum. So when a woman presents, whether she has all these symptoms or some, we're certainly going to want to do a good exam to take a look at this. Far and away, the two most common I have highlighted here as dryness and dyspareunia are by far and away. And you can see that dryness, about 85% of postmenopausal women report dryness, and over half report pain during sexual intercourse. So I talked a little bit about the prevalence of the onset, and here we start to get some idea of the duration. So as I alluded to, this is really a progressive condition. It's not one that, like vasomotor symptoms, which tend to have and onset around a couple of years before menopause, and then tend to taper down after the woman has been in menopause for several years. We typically think of vasomotor symptoms being around 5 or 6 years after the final menstrual period, although many of us have seen patients and we have patients that have hot flashes for the rest of their life. So it's not that all patients end their vasomotor symptoms. Some do continue on. But as compared to that, you see GSM can start before the final menstrual period, but continues to progress and increase with, again, it's really a matter of symptomatology. But again, unless there's another source of estrogen, every postmenopausal woman will experience this to some degree or another. So if we think about the vaginal pH changes with menopause, and in particular the loss of estrogen, we know that we're changing from that acidic environment, which is the result of the lactobacilli that is present right after the time of menarche, and present really throughout the reproductive years, where we have a pH typically in about the 4.5 range. Obviously, there's a window there, low 4s to about 4.5 or 6. And again, this is in the healthy estrogen replete environment with colonization of lactobacilli. Whereas in the postmenopausal time frame, with the change of the ecosystem there, we tend to have more bacteria like E. coli and coliforms. We tend to see an increase in the vaginal pH in the 6 or higher range, which is obviously makes for a very different environment, and then many of the things that we're going to talk about as we move forward here. So as we think about the vaginal microbiome, we talked already about the reproductive years, that right after menarche, really a predominance of lactobacilli. We know that there's a number of different strains, Lactobacillus crepidus, gasseri, jenseni, and inners. Other anaerobic bacteria can be present, certainly, but these are when things are not going in the right direction. So, and we're going to get into some of these things in a little bit more detail, but if there are the human papillomavirus or lack of estrogen or other factors going on that can then lead to a shift in the pH, number one, and then the bacteria that are present. So now if we go to the early side, the pre-menarchal time frame, again, there's not that preponderance of estrogen present. The microbiome there is with a scattering of different colonization of Corynebacterium, coagulase negative Staphylococcus, E. coli, Mycoplasma, and then at puberty it shifts, and then we start taking over the reproductive year environment with a preponderance of lactobacillus. Now, same kind of thing happens at the menopause transition. Again, we talked about with the loss of estrogen and some of those other factors, if they are present, again, at the higher pH in the vaginal environment, we can have much more anaerobic set of bacteria present with Gardnerella, Ureaplasma ureolyticum, Candida albicans, as well as Provotella. So decreasing lactobacilli in the postmenopause is considered physiologic. HPV positive women, there's a greater vaginal microbiome diversity and a much lower prevalence of lactobacilli. Fusobacteria are more common. And in the setting of HPV, the vaginal microbiome is further influenced by factors such as menopause as well as genetics. So the increase in estrogen levels, whether it's physiologic or whether we intervene pharmacologically, we can help restore that estrogen predominance. We can influence the pH in the vaginal area, and then increase the lactobacilli. So about 50% of the 64 million postmenopausal women suffer from symptomatic GSM, meaning that there's about 32 million women with genitourinary syndrome of the menopause. Now, the point of this slide is basically to show that unfortunately women are dramatically undertreated. 25% of those are using simply over-the-counter moisturizers and lubricants. And those are options. We're going to talk a little bit more about therapeutic options in a minute. 18% were past users of a prescription medication, not necessarily an estrogen product, which we'll get into as the most effective approach. But 18% used some type of intervention. 7% had been treated with a prescription medication currently, and then that leaves the rest who have not used anything for their symptoms of genitourinary syndrome of the menopause. Now, it's not advancing here. Let's see what's going on. There we go. Now, unfortunately, a lot of the reason for that is not necessarily the ones here on our discussion this morning, but we as the healthcare profession. And there's data showing, quite a bit of data, that unfortunately the discussion happens very infrequently. Less than about half the time is there even a discussion with the patient about the genitourinary symptomatology during the postmenopausal time period. And most of the time, it isn't the provider who initiates it. So this on the left side tells you how often was there a discussion about GSM. The right bar says who initiated. Was it the provider or the patient? And you see in many studies, the half patients that did have a discussion, most of the time it was because the patient was willing to bring it up or not embarrassed to bring it up. But we know that many times patients may not realize there's treatment. They may be embarrassed. They may not, for a variety of reasons. And so the point being, we really need to, again, not just us, because hopefully the ones here are a little bit more aware of GSM and the significance, but really as a profession need to be doing a little bit better job in terms of bringing up this discussion with our patients. Okay, so the goals of therapy, obviously to alleviate symptoms, preserve sexual function, and prevent UTIs. If you think of those three categories we talked about earlier, symptomatology, sexual function, urinary tract, that's our goal, is to, first of all, assess the symptomatology there and then help make an impact for the patients. There's tons of information data out there from many of our well-established organizations. Hopefully I've making a nice synopsis of it for you here this morning. But again, many position statements from NAMS, ACOG, and so forth that can be obtained and reviewed. Now, what are the options? I'm going to come back to the hormonal therapy in a minute and not really get into that much here because that's the most common as well as the most efficacious option for treatment. But there are other options. There's behavioral things such as regular sexual activity, whether it's self-stimulation or partner stimulation. This has certainly known to help with the functionality of the vagina and the tissues and vaginal health in general. Dilators, pelvic floor physical therapy when indicated. Over-the-counter vaginal lubricants and moisturizers. Now, you know that the moisturizers, they certainly help hydrate the tissue. You need to use them several times a week. If the lubricants, they can be used prior to as well as during sexual activity. But important to realize that neither the lubricants or the moisturizers reverse any of the physiologic changes that are the result of the loss of lactobacillus and the change in the acidic environment. Non-hormonal options, there's topical lidocaine, again, for symptomatology. There's laser, which we'll touch on a little bit more in a few slides. And then there's some newer options over the past number of years, including DHEA, SERMs, as well as some newer hormonal therapy options. So jumping into the hormonal options, the estrogen options, there's an abundance, and you can see them listed here. So I'm not going to go through everyone in great detail, but we know that there's creams, conjugated estrogens, as well as 17-beta estradiol. There's vaginal inserts that include the estradiol gel caps, estradiol hemihydrate, and then also the DHEA intrarosa. We have the vaginal ring, the 17-beta estradiol, aspemifene as a SERM, and then certainly oral contraceptives are used in many premenopausal, but many perimenopausal women are using them as well. So that is another option. Now, we're going to talk a little bit more later about treatment of GSM in the breast cancer patient, and really talk about the safety overall, not just in general, but also with patients with a history of breast cancer or patients who are worried about breast cancer. But oftentimes the concern that comes up is in terms of the dosing or the systemic exposure of estrogen. But you can see here, compared to an oral contraceptive pill, where a patient is getting around 365 milligrams a year, or roughly a milligram a day, you can see that many of these products, we're talking about a half a milligram a year for an entire year exposure to the product. And really the fact that many of these do not raise the serum estrogen levels above the postmenopausal levels in general. So whether that's a good thing or not, because there are many times you want a systemic exposure. So it's important to know this, not just for safety reasons, but for the fact that this is not going to give the patient any of the benefits of systemic estrogen. Okay, so all vaginal estrogens had, I have to change that. I've added some information in a few slides about the class box warning and the recent change, which we were all very excited about. All vaginal estrogens had, HAD, the estrogen class box warning, which was really very frustrating to many of us. And Steve knows well, he and I have been part of the discussions. We're on the board at NAMS together and have been on the board at International Menopause Society together through many of these discussions, and really a lot of work at the national level trying to help get this black box warning changed, where it had the same verbiage, the exact same verbiage of what the patient would get for an oral product, talking about the potential risk of heart attacks and breast cancer and stroke and dementia and so on and so forth. But even then, there's been data out there showing significant safety. Looking right from the WHI, we know that patients using vaginal estrogens compared to non-users had similar risks of all the outcomes: breast cancer, stroke, colon cancer, endometrial cancer, DVT, heart disease, all-cause mortality. There was really many of them had a lower incidence, but not statistically significant. So really, we've had the safety data for quite some time, and I'll come back and touch on the black box warning aspect of things in a minute. But as I alluded to earlier, over the last 15 years or so, we've now have some newer products, which is really helpful and to have in our armamentarium. Since the early 70s, really, when estrogen began to be used for menopausal therapy. Vaginal estrogen conjugated estrogen cream was really the only thing we had available. Estradiol cream came along, and then we started getting the vaginal rings. But over the last several years, we now have some other products, which we'll talk about: aspemifene, prosterone, gel caps, and so forth. So let's start with aspemifene, which is a SERM, a selective estrogen receptor modulator. It is FDA approved to treat moderate to severe dyspareunia. It's taken orally daily, and it's typically prescribed at 60 milligrams. It can elicit vasomotor symptoms, so that's important to know, especially if you have a patient who's already struggling with vasomotor symptoms. This may not be your ideal option. Its anti-estrogenic breast effect has been shown in some of the preclinical trials. It's not, however, approved in the US for women who are at high risk for breast cancer or women with breast cancer. But importantly, it's not contraindicated in Europe in breast cancer survivors after they've completed therapy. So it's, like many of these things, we just don't have the definitive data to clearly say that it can be used. But that's very important information to have in terms of your counseling on the risk-benefit ratio with your patient. Now, in terms of DHEA, the vaginal prosterone, it was approved in 2017 for moderate to severe dyspareunia. It's an intravaginal insert given daily. It's not considered non-estrogenic. However, the endogenous steroid, DHEA, is converted into androgens such as testosterone as well as estrogen. So even though it's converted at the tissue level into the products that are going to help make the therapeutic intervention, it's not considered estrogenic. The most common side effect is vaginal discharge. And so there's no estrogen labeling or black box. There is a warning in breast cancer survivors, although it's not absolutely contraindicated. Okay, so let's touch on the laser here for a moment, because this is something that has come up over the last number of years, and there's controversy surrounding it. The FDA warns against the use of energy-based devices to perform for vaginal therapy for genitourinary syndrome of the menopause. It is, however, FDA cleared. The product is a fractionated beam of light that penetrates small areas of tissue, and the way it works is by creating these small wounds in the mucosal epithelium that then can set up a chemotaxis reaction, a neocollagenase, and then angiogenesis with re-epithelialization of the vaginal layer, which is felt to be how it works and how we get the effect that is touted as being beneficial. It tends to be well tolerated. It's fairly available. The problem is that we really don't have great studies on it, and we also don't have really robust safety data for it. So one of the interesting newest studies was the effects of fractional CO2 laser versus sham therapy on symptom severity in women with postmenopausal vaginal symptoms, and that study showed no difference, and so that really kind of again raised some questions about the overall validity of the use of this. So it is cleared. There may be times where this is an option, but really is considered not a first-line therapy or intervention. Okay, breast cancer survivors and GSM. So there's 3.8 million women in the United States, and so obviously looking worldwide and internationally, and I recognize that we have many not from the US here, but this number of 3.8 million just in the United States alone and that number is growing by the year. So treatment of this population, and we know that breast cancer survivors often have some of the greatest symptomatology, menopausal symptoms in general, but certainly the GSM symptoms that we talked about. So it's a huge unmet need, medical need, with the majority of women going untreated, many times because they're fearful. And frankly, many times the providers are fearful to treat and to intervene. There's also, and I'll touch on this in a little bit, a real importance to touch base with the other providers who are helping treat the patient or getting an additional menopause expert involved, depending on your level of comfort treating these patients. These patients tend to be younger, because they're diagnosed earlier with breast cancer, and so they may have the onset of menopause younger than were the typical average age of menopause, and they have some of the most severe symptoms due to oftentimes rapid onset of surgical menopause, chemotherapy-induced, radiation therapy, adjuvant endocrine therapy. And so there's a huge impact on their quality of life, and again, the reluctance that patients can run into. So what are the treatment? We have certainly that include education, obviously, lidocaine, dilators. Then moving on from that with the interventions, and again, this is in patients with breast cancer, and the term we like to use, shared decision making. But importantly, as I pointed out, you're going to want to be talking to their oncologist, not so much for permission, not so much to ask if it's okay or safe, but to educate them often because they may not be aware. And under that, after that approach, and because if not, you're often going to leave your patient in a scenario where the oncologist or the family doc or someone is going to confuse the patient, say, "Oh my gosh, I can't believe you're on this therapy. This is dangerous." And now they're really in a situation where they're confused and they're getting mixed messages. But after making sure the care team is on board, looking at local estrogen therapy, vaginal DHEA, aspamifene, as well as vaginal laser. Now, there's no one preferred. We know that vaginal estrogen is considered the first line, the most efficacious. And fortunately, again, we have the black box warning has been removed. But again, there's still those underlying concerns that patients are going to have related to estrogen exposure. So it's important. Let me just come back here, and I guess this was not the one that had my couple new slides. So I'm going to touch on those new slides that I added for you, and then try to bring this to a wrap up so we still have a few minutes for some questions. Is that, again, there's some newer data that's out there really looking at the use of vaginal estrogen in breast cancer patients, showing really convincing safety information. And there's a very large meta-analysis that showed that there was no increased risk in recurrence of breast cancer, no increased risk in new breast cancers, and no increase in overall mortality. In fact, there was a statistically significant decreased risk in overall mortality, but it was very small, that you have to obviously look at the absolute risk versus the relative risk of things, and that certainly not something you're going to be using for long-term longevity reasons. But the take-home message is that local estrogen therapy, and again, some of these products, as I alluded to earlier, where you're getting a year exposure of about 0.5 milligram for the entire year, not raising the serum estrogen levels above the postmenopausal range. And in these newer studies, there's also data looking at the use in patients on aromatase inhibitors, showing no increased risk in that population as well. And so again, in those patients in that population, that's something you're going to really need to talk in detail with the patient about, or get another menopause expert involved in that discussion, as well as making sure that you're talking and having a good discussion with the rest of their care team. So bringing this to a close so that we can spend a few minutes taking some questions. GSM is highly prevalent. It negatively impacts quality of life and sexual function, and it remains underdiagnosed and undertreated in a large number of women. So really, again, emphasizing the point that we need to be bringing this up with our patients. Even if they don't bring it up, healthcare providers should routinely ask about this, examine for it, offer therapy, and refer if they need assistance or help with any of these aspects. First-line therapy, of course, we have all the lubricants, the moisturizers, dilators, pelvic floor physical therapy. But also, we should not shy away from the use of local estrogen therapy, DHEA, ospemifene. Again, maybe options for breast cancer survivors, because we've really talked about the safety there and the opportunity to help bring symptom relief to patients despite that underlying diagnosis. So with that, I will stop screen sharing so that we can spend a few minutes here.
Thank you very much, Peter. That was great. I guess as moderator's prerogative, I'm going to make a couple of comments and then I have questions for you. In this discussion about aromatase inhibitor and breast cancer survivors, you know, Professor Schnatz and I were people who went to the FDA at our own expense before they took away that black box warnings to try to get them to do that. And we had written an editorial called Why the Product Labeling on Low-Dose Local Vaginal Estrogen Should Be Changed. And each one of us sort of had a different role. And what I did was I reviewed the serum levels of the various trials. So I want to share that with you because I think it's germane. In a lab like mine at NYU, if I send out a serum estradiol, I will often get back a report of less than 20. They don't necessarily give me a number. When you do a clinical trial, you need a more sensitive kit. You will actually get the exact number. And so in the VagiFem, 10 microgram tablet trials, the average serum estradiol in women who put 10 micrograms of estradiol into their vagina was 9 picograms per milliliter. In the placebo group, it was 9 picograms per milliliter, which is why we say it's not absorbed, average. If you go on an aromatase inhibitor, your serum estradiol levels are often brought down to less than 1. So if you really have a patient who needs to be on an aromatase inhibitor who has a more advanced breast cancer, if you not want her to have a serum estradiol level of 9 as opposed to less than 1, you may want to consider that. But for your garden variety breast cancer patient who's finished her tamoxifen or 5 years out, I don't think there's any question that these estrogens are safe. And it kind of is a great segue into the notion that there is a tremendous overutilization, I think, of aromatase inhibitors in some of these early stage breast cancers. The other comment I wanted to make was understand that we are higher order primates, and other higher order primates like chimpanzees, gorillas, they only live a year or two after they stop reproducing. Our patients spend 40% of their lives in a post-reproductive state, which is why you need to be thinking about what's going on in the vagina. It's interesting. If you look at typical hot flash studies, clinical trials, average age is usually 51, 52, because that's about the peak of vasomotor symptoms. The average age in these VVA GSM trials is 59. Because in order to get moderate to severe vulvovaginal atrophy, which is what the FDA still uses, nomenclature, the older you get, the further into menopause you get, the more atrophic it becomes. My question
Yeah.
for you had to do with parity.
And Steve,
Go ahead.
before you jump here, are you seeing my screen here?
Yeah, we're seeing you.
Okay, so here's the slides that were in the talk that I had
Oh, okay.
updated. But so you can see experts have been working for almost 2 decades to get the FDA box warning removed. And it was titled, as Steve said, Why the Product Labeling for Low Dose Vaginal Estrogen Should Be Changed. And what we said was we submit that revisiting the labeling, the black box warning is based on explorations of data from trials on systemic estrogen, which involve substantially higher levels of exposure. Our view is that it's the highly visible box warning is unsubstantiated and not evidence-based. We believe that women would be better served by a modified label that more closely reflects the safety profile of low-dose estrogen and could ultimately enhance safety by emphasizing the key information that women need for this, for local estrogen. So we recommended that we should bold the phrases, report any vaginal bleeding or spotting right away while using whatever particular product, and that women with a history of breast cancer, with cancer of the breast or uterus, or other hormone-sensitive cancers are encouraged to consult their oncologist. Yes, yay, the black box warning was removed. I talked a little bit about how the data came that we became worried about using it in patients with breast cancer. But here's the data looking at estrogen and breast cancer survivors. And you can see that for the vaginal estrogen and breast cancer survivors, recurrence was 0.48, so lower incidence of recurrence in patients with using estrogen therapy. Breast cancer mortality, no difference, no statistical
Your
difference.
slide
And overall
in advance,
mortality.
Peter. You're still on the line.
What's the, oh, sorry. For some reason, the internet must not be advanced.
No,
Is
it's
it
still
advanced?
why the product labeling should be changed.
Oh my goodness! Wow, I'm a number of slides ahead. In any event, the point is, it's just some. It's probably now going to rapid fire through those. Let's see if it. I'm just going to leave it on this one, which is a summary one of the data that I just showed. That once it gets to it, it says vaginal estrogen and breast cancer survivors. Is that showing up?
Yes.
Okay, so this is the overall summary of large meta-analysis of all the data, and you can see that that everything is on the decreased side in patients who are treated with vaginal estrogen. So,
My
okay,
other
go
question
ahead,
for you
Steve.
had to do with, when you get the patient with dyspareunia who's got VVA GSM, how does their parity or how they delivered enter into your decision making as to what you might choose? Let me refine that a little bit. I have found that, when we check pH and vaginal maturation, they do that, 4 inches into the vagina. For many of these patients who have nulliparous or only had cesarean sections, their problem is the narrowing of the introitus, as opposed to the true atrophy in the vaginal mucosa above it. And so I don't know if you differentiate that, but I tend to not only use cream, and I'm not a big fan of dilators, but I do teach patients how to sort of stretch the introital opening, with either the estrogen or with some lubricant. And I find that that's a main source of their dyspareunia sometimes is not just the atrophy, but atrophy coupled with never having delivered vaginally. Have any comment about that?
Yeah, no, that's a great point. No, I think that's a great point, and I think I mean you mentioned in patients who have had vaginal delivery. I guess it could be for any reason that they have vaginal laxity or prolapse. Obviously, that's one of the main risk factors for vaginal laxity and prolapse, but they could have prolapse for other reasons. So I think, I tend to lean more on, the examination. Obviously, you'd be less likely to recommend dilators in patients who have vaginal laxity and prolapse and so forth. Whereas that may be much more beneficial in a patient who is nulliparous, who's not sexually active, where there is no current vaginal activity, whether it be self-stimulation or partner stimulation or whatnot, would be a time when that would be a more potential value.
Dorcas and then Elizabetta.
Thank you for the thank you for the
Dorcas.
presentation. My question is on prosterone. What your experience would be if there is a release or conversion of testosterone? Would it be significant enough to help those with low libido and that group of patients who comes with that plus the libido issues?
No. I think if I'm understanding your question correct, is that would the local treatment with prosterone potentially benefit their systemic hypoactive sexual desire disorder? And the answer should be no. Now, if you give it to a patient and she says my sex drive feels better, well, okay, that's great, but really it's more local there, and there really should not be much systemic absorption.
Thank you.
Elizabetta.
Hi, thank you very much. I wanted to ask, since the safety profile is so good for vaginal estrogen, do you recommend it as a preventative measures for people with no atrophy complaints?
So that's a good question. I think that question comes up more in terms of systemic estrogen, because that's where you're talking about is there cardiovascular benefit that would be present. And Steve and I would tell you in these rooms where there's 10, 20 experts, it's really the room's divided, with many people feeling like the position statements should say that in a young, healthy woman, certainly if she's right at the time of menopause without any underlying contraindications, that there may be some real strong benefits. Whereas other people are going to say, well, we just don't have the prospective double-blind randomized trial to convincingly say that. But those things, systemic estrogen for bone health and for the vascular implications and so forth. But local, not necessarily needed to prevent vaginal atrophy, because if they're not having symptoms, then then it's really not necessary. Now, I suppose you could say if they're having stenosis and so forth, where it's going to be difficult to examine, or that it's worsening. But I've never seen that without a patient being symptomatic.
I think it's a lot about initiating a conversation. In other words, as opposed to saying the attitude that we're going to treat everybody at menopause to prevent moderate to severe, VVA GSM. It's a matter of alerting people to the fact that other primates don't live this long, that if they start to experience any symptoms referable to the atrophy in the vagina, that they should alert us, that they might want to be treated. I think it's an education, and it's initiating a conversation, not necessarily pushing the medication. But you could make a case for estrogenizing vaginas at menopause. And in other words, realize that all these studies are done on reversing moderate to severe symptomatology. The idea of prevention, it's certainly safe enough. So I think on a case-by-case basis. Marianne and Swaja.
Thank you for a nice lecture. I was wondering if somehow in the line of what Elizabeth asked about, because would there be a window of opportunity here as well? Could it go so far that it somehow gets too late? If the woman has had symptoms for a long time, it gets really stenotic, can she be untreatable?
Again, I think as Steve pointed out, it's a case by case discussion. And if you have a patient who's extremely worried about it, maybe she had a mother that had severe atrophy, and on the other hand, it tends to respond extremely quickly. So I haven't seen cases that are resilient to intervention. So I don't think that's a huge worry. And in other words, if the patient said, again, I'm extremely worried about this. I'm having some mild symptoms, but really nothing significant. I'd lean more towards treating early versus if she's asymptomatic and you're seeing no symptoms. I'd probably lean towards not treating locally. But again, it's an individual discussion.
Swairaj.
Thank you, Professor. I have a question, like if someone has a repeated urinary tract infection and there is no culture is negative, do you think the local application of estrogen is going to help her?
It may. I think that's a scenario, where you're getting, she's complaining of UTI type of symptoms, but you're not getting a positive culture. And symptomatology can vary from patient to patient. What she's sensing could very well be lack of estrogen and the irritation to the bladder, base of the bladder, and causing some bladder cramping and so forth. So I would, without a doubt, in that scenario, try it and see if it makes a difference. Yeah.
Thank you.
For sure.
Thank
Yeah. Zanat. You're muted.
I think your mute's on there. It's still muted. Are you able to unmute that?
Technology.
No.
Yeah.
You could put
Thank
it
you
in
so
the,
much. Thank you
could
so
put
much.
it in
Yeah.
the chat.
Right. Okay, this is a very, very good and very elaborative lecture indeed. So my question is that I have got so many women that I am giving her local estrogen for genitourinary syndrome of menopause. Some are responding very well. Some, if I stop the hormone, they come back with the same repetitions. So what do you think? How long actually I should continue for those group of women who are not, who repeats the problem if we stop the local estrogen?
So when you stop the local estrogen, their symptoms return fairly quickly. And the question is, how long do you continue treating?
Right.
Keep treating, I think. And so with hormonal therapy in general, whether it's systemic or local, it's a yearly discussion. Patients will often say when you start out, oh my goodness, doctor, am I going to take this for the rest of my life? We're going to go year by year. And each year you're going to rediscuss what are the indications, why are you on it? Do we have any new evidence to guide us? And if there's still an indication, then you continue to treat. And in that scenario, especially with the local vaginal, is so safe. The safety profile is extremely safe. And if there were some hyperstimulation of the uterus or whatnot, we're going to see some bleeding that we'd evaluate. So it's a matter of counseling the patient, reminding them of warning symptoms. But if it's returning after stopping, I'd continue therapy.
A couple of practical points, that sometimes get lost in the shuffle. Certainly things like the Vagifem, Uvifem, the ring are pre-dosed, so you don't need to worry. If you're giving people cream, you need to show them, because we tend to want to use 1 gram, and the applicator on the ones that we have here available in the States have 1, 2, 3, 4 grams. If you put enough estrogen into the vagina, it's going to get absorbed. In addition, we normally give 2 weeks of a loading dose nightly and then twice a week. You need to manage expectations. In the clinical trials, there was some separation from placebo at 2 to 4 weeks, but it doesn't maximize for 12 weeks. So patients need to understand when you give this, that what they feel at 12 weeks is what they can expect to have going forward. and that they're not going to use this 3 times and all of a sudden be all better. I usually tell people, it took a long time to become atrophic. It takes a little while to reverse it. Last question from Mary Ann then we'll have to stop.
Just a quick one to follow up on this. How many times a week? I know it's the Vagifem or the estradiol tablet. It's usually a loading dose 14 days, once a week, and then twice a week. But is it okay to take them 3 times a week, just in case it's not enough, like every second day? Or
So
are we getting to a load?
What I was saying was the loading dose is every night for 2 weeks.
I know.
But you make a very
even-
good point. I do have, you realize when Vagifem first came out, it was 25 micrograms twice a week. So that was a total of 50. Now we're giving 10 twice a week, and then so there's a 4 microgram, in Vexi. And I do have some people, and especially patients who are very thin, who are making no non-ovarian estrogen of their own, in whom I've gone to 3 times a week with some monitoring, but that's just going to be a total of 30. So for years, we used 50 micrograms when we were doing 25 twice a week. So occasionally, yes, that's why you individualize.
And the nice thing about, especially in a patient where there are not concerns for systemic estrogen, there's tons of flexibility, and you can really let the patient gauge it. If twice a week is enough, go to 3, maybe 4, 5. You can really let them play around with it in terms of frequency. Again, as long as you're not worried about the systemic absorption.
Well, it's 15 past the hour, and we usually want to be mindful of people's times and commitments, especially Dr. Schnatz's and mine, since I already heard them putting patients into the room, my consult room. Thank you, Dr. Schnatz. That was wonderful. Thank you all for a really good discussion. Can we show the last 2 slides, Marianne? I've been bad sometimes. Don't go away. The IMS wants to make sure that I show you these 2 slides. Marion, help me. Well, one of the slides was to promote the World Congress, which will be September 29th to October 4th, I think it is, in Rio. Oh, here we go. And the other slide is, once again, to show you all the things that the IMS is doing, the World Congress, our journal Climacteric, all of the online education. Menopauseinfo.org is for consumers. CAMS, the Council of Affiliated Menopause Societies, our World Menopause Day every October 18th. There's a QR code here, or go to IMS Society, which is 1s.org, for all of the things that you can do and that don't cost anything. In addition, you realize that you can become a limited professional member of our society for free through your, that's also available on the website. Next slide is just to remind you that we'll be in Rio September 30th to October 3rd, and I hope to see all of you. Sometimes the colloquium people have been able to arrange a little gathering of you guys and get together. So as we get closer to October, maybe we can arrange that. Until next month, once again, thank you all, and thank you, Peter Schnatz. Bye-bye.